All right. Hello, everyone. Welcome to a Tuesday VMR. I'm so excited because I have the privilege of co-discussing this case with the incredible Ravi. So really excited for the session. And we have a first-time case presenter here. And so we'll hear from the scribe and the person doing teaching points as well. But Manaswini, I'm sorry that I know that you gave your introduction before, but for everyone who's listening to this, do you mind just reintroducing yourself, where you're calling in from, and what your interests are?
Yes. Hello, everyone. Thank you, Maddie. Thank you, Dr. Singh. I'm really excited to be presenting my first case. I am Manaswini Keshav, a recent medical graduate from India. I did my medical school in Ramaya Medical College, and I'm currently working as a medical officer in a tertiary care center in my hometown. And I've been following CPS for quite some time, and I'm so excited to be here presenting my first
Incredible.
case. Yes, and outside of medicine, I love just spending time with my friends. And I've recently picked up playing the violin, so that takes a lot of my time. Yes.
That's incredible. Well, thank you so much for presenting your first case. I feel like I recognize you from VMR. Have you been tuning into VMR? That's yeah. Well,
Yeah.
congratulations on presenting your first case. I hope it's the first of many. And thank you so much for being here when it's kind of late in the evening your time.
Oh, it's my
We
pleasure. Yeah,
perfect.
definitely looking forward to presenting more. Yes.
Awesome. Well, we want to hear from Eugene and Bayan, who were doing teaching points and scribing. Eugene, do you want to unmute? Say hello. Are you back from your trip from London?
Yeah, hello. So my name is Eugene. I'm a medical officer from Ghana. And yeah, I'm back from the trip from London, back to work. So I'm actually excited for this case. And yeah, I'll be doing teaching points.
Awesome. Thank you so much. And Bayan, do you want to unmute as well? Thank you so much for doing scribing.
Yeah, hi everyone. I'm Bayan. I'm an intern from Syria, currently on my ICU rotation. And really excited to be back because I've been not very involved in the space for a while.
Well, it's so good to see you, Bayan, and thank you for doing scribing. And Ravi, do you want to say hello? Ravi's doing a simulation later today, so we're lucky to learn from co-discuss with you before that.
Yeah, I was just sharing in the room. I was showing them one of my slides for simulation. So put interns through my nightmare course, 10 cases that they need to know for the floors. But absolutely stoked to be discussing after a long time. Maddie, it's been such a long time. The initial origins of the academy back many years ago. You were a med student, and I've just shown your evolution through CPS, and you continue to train and move on from being a student to intern, now resident, and you continue to cross paths with VMR, not just go away and do
Yeah.
your own thing, which just speaks volumes. I think once you've joined VMR, the learning is ongoing and continuing. So really happy to see you back and see the growth that you've gone and produced out there. In Colorado. So very excited to come back and have you come back and discuss today.
Yeah. Oh, thank you so much, Ravi. Yeah, VMR is my family. I feel like, and it's been such a pillar of my like journey through medicine. And so, yeah, VMR is the best place ever, and so excited to learn from this case. Let's get started. So I think Bayan, you can go ahead and share your screen. And Manaswini, whenever you're ready, you can go with the first aliquot.
Okay, great. Thank you. So here comes my first aliquot. A 29-year-old man presented to the emergency department with right foot pain for 3 days. He had sought medical advice 2 days earlier at an urgent care clinic, where he was diagnosed with plantar fasciitis and was sent home with ibuprofen. However, the pain persisted and continued to worsen. 2 months before the current evaluation, the patient began to experience fatigue which was preceded by 6 months of generalized body aches. That's my first aliquot. Would love your thoughts.
Well, Maddie, it's not nerve pain or neuropathy this time. The joke is we've always had neuropathy as the initial. It could be still, but as initial chief complaint. But I'd like to hear your thoughts for this initial aliquot. Go ahead.
Absolutely. I know, Ravi, we'll see if this becomes a neuro case. But Manaswani, I just want to shout out how you're presenting this case. I think this is such a perfect place to pause, and I love the sequence of events and how clearly you laid that out. So, just to summarize where we are, so we have a young person who has, unilateral acute onset foot pain that seems to be preceded by more systemic symptoms with fatigue and body aches. Whenever you have kind of a pain in one extremity, I find it helpful to think through an approach that's based on anatomical structures. So you can really apply this to any extremity, whether it's the right arm, the leg. But I think for the right foot pain, the different categories of disease I think about is this an issue with the skin and soft tissue? So for example, a cellulitis, a deeper infection like necrotizing fasciitis. So skin and soft tissue is one category. Is this an issue with the vasculature? So things that you don't want to miss is this acute limb ischemia, acute on chronic limb ischemia, peripheral arterial disease? So skin and soft tissue, vasculature. And then you also think of the basically osteoarticular apparatus. So is there an issue with the bones, the muscles, the tendons and ligaments? So those are the three kind of big categories I think of. And of course, some really key questions here are, was this preceded by any trauma? We're not getting a history of that, but that's really something that I would really want to clarify with this person. Right foot pain that seemed to come on 3 days ago. So was there any type of fall, twisting the ankle, hitting the foot on something that, because you don't want to miss basically a fracture or something like that. I think what's really interesting here is that the patient was given an initial diagnosis of plantar fasciitis. And so it'll be interesting to think about kind of what were the clues that prompted this, the physician at an urgent care to apply that diagnosis. And, my understanding of plantar fasciitis is basically you have pain on the plantar aspect, plantar aspect of the foot, but particularly towards the heel. And generally that is, I think I even had plantar fasciitis one time. I think it's basically preceded by really intense, like walking a lot more than usual, maybe in shoes that are not really supportive. And generally, with plantar fasciitis, the cases that I've seen, visually, when you look at the foot, it won't look so red or swollen. And so I think the visual inspection in someone with plantar fasciitis may be normal. So I think I'm curious if the visual inspection of this foot at the urgent care was totally normal, and perhaps the physician kind of pressed on the heel and there was tenderness there. Maybe there was a history of walking longer distance than normal, maybe in not in supportive shoes. So we'll pause there. And Ravi, curious how kind of we got this history that the right foot pain is kind of acute, but then it's preceded by, a more chronic fatigue and body ache. So I'm curious how you're incorporating that.
Yeah, I want to start with Maddie. You've done an absolutely wonderful deep dive into this. It's not every day we're like thinking about pain in the foot, but this I could see in the resident clinic, a patient coming, and I get very excited because it's like you have nothing accompanying the patient. You just have the foot and everything is happening in the foot. But now what I will do is I'll separate the foot and the upstream complaints of fatigue, which will make it a systemic process. But if we just take the foot, it's kind of odd in a 29-year-old. What do you usually see? I mean, if I talk to my podiatry colleagues, what would they see with a young person with foot disorder? Mostly sort of trauma-related issues, ankle sprains, and you may see any sort of overuse, tendinopathy, any of these different things. If there's trauma, of course, any sport-related injuries, plantar fasciitis for a young person. If they have an anatomical deformity, say the arch, right? A lot of issues can happen when there's a lack of an arch or the arch isn't supported. So you actually hit the needle on the head. I mean the nail on the head with poor shoe support. Sometimes we don't even think about how important shoes could be. If you are a runner, you need to switch out those shoes because the rubber in the shoes gets used or doesn't provide as much support over time. So it's absolutely crucial changing out shoes if you're doing any sort of activity or standing for a long period of time. Now, plantar fasciitis is interesting, right? Plantar fasciitis can be associated with many systemic conditions as well. So it may not just be the foot, it may be an indicator of something that may be inherent to the patient. Again, a young patient is very odd, usually plantar fasciitis, or any of the other associated conditions with the feet, podagra, CPBD. Older individuals, usually we see vascular compromise. If we're looking for red flags, we always kind of train ourselves to think of worst case scenario, something I do not want to miss. With this, it may not be something that's ominous, but maybe related to something upstream. But there is an exam that we do, I remember, with plantar fasciitis, which is the windlass maneuver. So you take the foot, so you take the ball of the foot, you take the toe, and you flex the toe up, and it should elicit pain along the plantar fascia. And if that's positive, it's plantar fasciitis. So do use that. It's very useful. I remember when we had people come, work-related injuries, workers' compensation for foot-related pain, anything like that. So that is a useful maneuver to do to elicit pain along the plantar fascia. But at this point, what really has my antennas up is this fatigue and body aches. Now you're thinking, okay, the foot is just a fingerprint of maybe inherent disorder. What is going on with this fatigue? A 29-year-old shouldn't be fatigued, right? And this should trigger a number of schemas, but I really like the anatomical approach. Yes, look first, examine, look at the skin, look at the tendons, look at the ligaments. If you think about it, the foot is a very articulate kind of a feature. I mean, articulate extremity in that there's so many bones and ligaments between bones. So there's so much that could go wrong with the foot itself. But let's get some more data to figure out what is this fatigue and how long the patient had it for, and anything in the history that could trigger this fatigue.
Love the
Okay.
approach. That was a great discussion. Yes. So thank you. Coming to the second aliquot, he described the pain on the plantar surface and the lateral side of the right foot, which intensified with weight bearing and was not relieved by any specific measures. He denied recent trauma. He denies fever, chills, weight loss, or any joint pains, and there is no associated hematemesis or melena or hematuria. He has no significant past medical history, mentions of a nose surgery. He's not on any medication and has no allergies. He works as a roofing laborer and also a community ambulator and is quite active at baseline. He does not smoke, use alcohol, or illicit drugs. In family history, his mother has a history of breast cancer but is currently doing well. He has a sister who passed away due to suicide. Coming to the vitals, he is afebrile, mildly tachycardic at 118 beats per minute, 20 breaths per minute, and blood pressure of 136/86, and saturating at 97. On general physical exam, the patient is not in acute distress, oriented to time, place, and person, and he's coming to his physical exam. It was unremarkable in the cardiovascular exam was mildly tachycardic with irregular rhythm. On pulmonary exam, the lungs were clear bilaterally with no adventitious sounds, and abdomen was unremarkable. On musculoskeletal, there was normal range of motion except where it was limited by pain. There was focal tenderness over the plantar and the lateral midfoot and the ankle region. And passive and active range of motion was limited due to the pain. The skin exam was unremarkable. Coming to his labs, the WBC on CBC, his WBC was 11,680. His hemoglobin was 10.7, which is low, and hematocrit of 32.3. Platelet was normal at 272. MCV was 76. Total iron binding capacity was 203, which is low, and iron saturation of 11. But the ferritin was 369, which was normal. His electrolytes were within normal limits. LFTs were normal. His CRP was raised at 133, uptrending, and ESR was 59. And that's my second aliquot. Would love your thoughts.
Okay, great job, Maniswini. What we could do, we have quite a bit to unpack here. I'll tackle just some of the elaboration on the history, Maddy, and then the past medical history. And then you can tackle the exam. It kind of does correlate with some of this HPI that we got. But just starting with that, the pain has been sort of localized to the plantar portion as well as the lateral portion, and it's made worse with weight bearing. So you can imagine the patient putting the foot down, and then with the weight on top of it, the tendons, ligaments, the bones itself are now getting a lot of pressure from the top, which is exacerbating the pain. So occasionally with musculoskeletal disorders, when you move any sort of maneuver that is active, could be possibly muscle related, and anything that's like passive, you're taking the muscle out and just kind of moving the ankle or the foot. It could be related to the joints and ligaments as well. And in this case, though, the pain is made worse just with putting pressure on. So it could be any of these different structures. And then you have to consider like what kind of, if there's no trauma, there is a background of the patient working in roofing. And if you've ever been up on a roof, I don't recommend going on a roof. The likelihood of falling if you're not professional is very high and can result in a number of different injuries, spinal cord injuries, and so on. But if you ever seen roofs, like a lot of these roofs are slanted. So you have to anchor yourself and also use boots, and your foot is usually kind of like this if you think about it, and you're up there all the time unless you're down on your knees putting up shingles. It's a lot of hard work, especially going up and down ladders, and you're taking the shingles up to the top of a roof. So you could imagine your feet are pretty much going to be tired. But I think here the younger patient, young people shouldn't develop pain like this in the feet like this, or the foot in this manner. Again, what gets me, if we start talking about esoteric conditions, where you're thinking about fatigue, body aches, could this be something of a systemic autoimmune flavor? If we look at those, a lot of those can be symmetrical. So rheumatoid arthritis comes to mind, symmetrical, right? So that does tend to affect the small joints of the feet and the hands. Here, so far, we have no features of the hands. So what's usually spared is the distal interphalangeal joints and the metatarsal joints. But this is 1 foot. So we don't know if this is the start or maybe a process like this, or this person's on a journey to an autoimmune phenomena. But what makes me move away from that is the non-symmetrical nature of this, what you highlighted initially, Maddy. But moving back to this, I don't think there's other alarm systems like vascular compromise, one other cause that I've read about before is Morton's neuroma is a common, you probably read about this, that you do see in people. And it's annoying pain, and you see on physical exam this bump, but we're not seeing anything at all in the extremity, no asymmetry, no protrusion, no lesion, nothing to really hang our hat on. So at this point, I'm not even going to go into the labs, but just looking at that it's just a painful foot. It's nothing's on the surface, something's intrinsic, and this fatigue plus foot. If you marry fatigue, lethargy, body aches, then you're going into a muscular or enteropathy kind of thing. So you have to start playing with, is there associations? Autoimmune phenomena can have associations with the gut. So IBD, celiac disease, one of those things. Could this be, if we saw a sausage digit, could this be psoriatic arthritis? So somebody talked about reactive arthritis. You do see that in young people. So then you have to consider the spine and so on. But I'm not getting a lot here to really move into that area and commit to that domain. So kind of odd. Is there anything for the exam, or even venture into the lab, since we have the labs? What helps you to make progress in this case, Maddy?
Yeah, Ravi, that was a brilliant discussion. And I think, one of the things I'm trying to grapple with is we have this right foot pain, and then we kind of separately have signs of more long-term, possibly inflammation between the months of fatigue, generalized body aches, and this, anemia as well. And so I'm wondering if these two are related or completely separate. Like, does this patient have an underlying reason to have some signs of systemic inflammation, and then separately he has just an acute injury to his foot? Or are these two related? So I think those are kind of two paths I'm considering in my mind. And then, like you, I'm trying to kind of try to localize the issue within the foot. So for example, is this an issue with the fascia, like a plantar fasciitis, or is there some type of joint issue here? And I think what's tricky is the range of motion was limited by pain, but I would be very curious to know, is there signs of synovitis in the ankle joint? Is there any swelling or redness? And of course, in real life, you would just be able to kind of see the redness, see the swelling. But I think when the range of motion is limited, like, that makes me just question, is there some type of inflammation? Is there like a joint issue of the ankle, or where exactly is the pain that's limiting the range of motion? Is it only on this kind of lateral aspect of the right foot, or do we need to be worried about a joint issue? So that's something that on exam I would really just try to palpate to see if there's any joint issues there. But and then I think practically, just for the foot, if I was seeing this patient in either the ED or in clinic, I would probably start with just a simple x-ray of the foot to see if there is any, basically to look at kind of the osteoarticular category. Is there some type of fracture there? Sometimes in the x-rays, you can see kind of swelling of the joint that would make us question, is this really a joint issue or kind of a bone, muscle, tendon issue? And then the labs are interesting. We have this mild microcytic anemia, and I think always for labs it's helpful to go back to see if we're able to, what are the previous values, to see, is this an acute change? Is this chronic for him? We're seeing kind of like a mixed picture here, where we see an elevated ferritin, but I believe I heard a low iron saturation. And so generally, if you have, iron deficiency, you see a low ferritin, usually kind of less than 30, and a low iron saturation. Usually the threshold, I think, is like, less than 25%. I believe I heard an iron saturation like the 11%. And so, does this patient have, there's the low iron saturation makes me think, is there evidence of iron deficiency here? But you see an elevated ferritin. So that brings into question, is this more basically anemia of kind of, is this suggestive of kind of chronic inflammation? Because ferritin indicates iron storage. And so when you have inflammation there, your body kind of stores iron and kind of like protects it from being used. And so is this suggestive of a more kind of chronic inflammatory state, also suggested by like the elevated inflammatory markers? I think practically I would just start with an x-ray, because the main reason why the patient is coming in is this right foot pain. And I would go from there. Ravi, I'm curious what your next steps would be.
Yeah, so I wanted to reserve that and not venture into inflammation you mentioned. So you're absolutely right. I think this is the catalyst to get us to the answer. So you mentioned inflammation, young person, epidemiologically, what can cause that? If you think about it, right, the most common causes of, I hope nobody gets plantar fasciitis, because it's very painful and it's very annoying. And I remember my time I had one, because I did change my shoes, and we have to walk a lot in the hospital. So definitely I recommend changing out your shoes for good foot support. But it hurts. It is very, very painful. And resting, usually when you have a unilateral plantar fasciitis, you rest. You can use a brace at nighttime. What happens is the feet relax, right? So they go down. And what happens in the morning, as soon as you get up, you flex the foot, and then the scar tissue that's forming, because what happens is that plantar fascia is injured, so the scar tissue then breaks, and it feels like 1,000 pins in your feet. So to help with healing, you have to wear a brace to keep your foot like this, so that your foot heals. So with that, usually, conventionally, it will get better. But with this patient, it's been a few days. And it's very odd, like 3 days, but this preceding this weakness that's been mentioned, and again, that question mark comes into play. Like, are we dealing with a autoimmune? I just got this flavor, right? Epidemiologically, this, and then what you have to do is venture into what can cause plantar fasciitis. I think no doubt this is plantar fasciitis from the way it's being described. And there have been so far no alarming features. The white count's a little high, so it may be the thermometer for information in this person. And then what I found really appealing, I really liked, yes, there's anemia, chronic inflammation, but there also could be concomitant iron deficiency anemia. If the ferritin, or I mean the percent saturation is low, less than 10, it is, if it's markedly low, it can be iron deficiency. Less than 20 is suggestive. Or this test that I've never been able to order, the soluble transferrin receptor test. We don't have that, but that doesn't get swayed by inflammation and could give you the answer if there is concomitant iron deficiency anemia and anemia chronic inflammation. But what really is interesting, look at the SED rate and CRP. So they're very high. Those tests can be very non-specific, but I'm going to use these and try and elucidate as much as possible out of them. I'm going to sort of use that as my lifeline, try and figure out what's going on in this patient. So in certain conditions, CRP being way higher, so CRP can swing up. So there's certain infections and abscesses where this can happen. Then there could be several autoimmune conditions where it could also happen when the CRP goes up. SED rate takes a little while to catch up. So again, revisiting, we have symmetric autoimmune phenomena, lupus, rheumatoid arthritis, mixed connective tissue disease. Kind of weird. It doesn't fit the picture. But yeah, I think there's so if we have a person with foot pain gets better, it's plantar fasciitis. If it's not getting better and it progresses, I just wonder if in this story, if Manaswini gives us a story that now the other foot is hurting, there's also intrinsic GI symptoms. I would ask, are there any GI symptoms in this patient? Are there any other joints involved? Is there skin involvement? And take it from there and see if there are any other developing features. Because, like the autoimmune conditions, it's not a snapshot in time. They develop over time. So we have to follow the patient over time, and it can reveal the diagnosis. But I think at least doing, what would be really helpful, Maddie, is doing just the regular autoimmune panel here.
Yeah.
And just see if anything pops up. Start with an ANA if the titer is like greater than 1 to 300. They say 1 to 80 but like 1 to 300 is really knocking the ball out of the ballpark. And would you do imaging? At this point, do you feel like, is it high value care to do imaging for this patient?
It's a really good question. I think, well, I'm curious what your opinion is on this. I think I would probably start with an X-ray of the foot, because before going down the I think there are some signs that there is signs of inflammation here. So I think autoimmune diseases are important to consider, but I think I just want to make sure I'm not missing a fracture or something that can be identified on an X-ray. And I think of that as just kind of a pretty easy, cheap test. So I think I would start with an X-ray. But curious if you have a different opinion on that. But then one thing I wanted to add, Ravi, you mentioned kind of in a young person, signs of inflammation, considering autoimmune conditions here. And I remember from one of the previous rheumatology subspecialty VMRs, I'm thinking of kind of the enthesitis here, which, my understanding of that is you basically have inflammation where kind of tendons insert onto bones. And my understanding is that you can have that and be associated with some, autoimmune conditions. The ones that I think of are like spondyloarthritides that can have enthesitis as part of that. And so I'm wondering here if the plantar fasciitis is an example of an enthesitis here. And, in many cases, plantar fasciitis is just, they've been walking a lot, not great shoe support. But given that we don't have a history suggestive of that, it hasn't improved with supportive care, do we need to think about this as enthesitis in the context of like an autoimmune spondyloarthritis? And then if we're trying to connect, is there some possible iron deficiency here? You have kind of IBD associated spondyloarthritis, you have psoriatic arthritis as well. So I'm curious if that space is relevant here, and if we are kind of moving into the autoimmune conditions. But wanted to pass it back to you, Ravi, to see, do you have a different opinion on the X-ray, and what is your thought on that?
Maddy, I think you sold me on the X-ray. What if we are sitting on trauma, right? You never know,
Yeah.
right? Start with basic. What's common is common. You have a fracture, and that could explain it, right? So I do like that opinion. So a lot in medicine, sometimes we don't know. This is management reasoning. Who loves management reasoning? Yusuf here. You can ask him, is a big fan of management reasoning. So this is a prime example of management reasoning. If we can't figure out, this is not like one rule fits all patients. So I definitely would you sold me on that. I didn't think about it. We kind of left trauma back in the early stages of the discussion. So yeah, get imaging to see. If the imaging is negative, then move on to more of the less common diseases. And I think enthesitis here, which is we're trying to find, what exactly is that? It's inflammation at the site of insertion of certain tendons. And we kind of didn't define it, but the plantar fascia is like a long tendon inserting into the base of the foot, and also the heel of the foot. So that, Achilles, and so on. So a good exam would be looking at all the different tendon, ligamentous joint. In med school, we kind of remember, or we're taught, like ankylosing spondylitis, HLA, I'm forgetting now, B27, we have to think about, if I remember. But we also think about the spine and the bamboo spine and so. So a lot of the pain is the hips and the spine, and also the enthesitis that you could get. And then part of the seronegative spondyloarthropathies, you have psoriatic arthritis. We remember the sausage digits and so on, looking at that. And then the nails, the pinning. So we would have to look, if you've ever done a rotation with a rheumatologist, they will go from the hands, feet, looking at everything for any sort of visual clue as to what may be going on. And the GI thing as well, asking questions, because could this be IBD, celiac related as well? So any of these features we definitely have to think about, and these visual clues in trying to determine what's going on. But I think, yeah, we're dealing with a tendon. I'm very much honed in on the tendon related conditions. And if there's any more that people have in the chat, I guess Mark mentions 50% of patients with IBD enteropathy will present extraintestinal manifestations. So yeah, we've had conditions like I presented a case of a patient with ulcers without IBD manifestation, but it was an extraintestinal manifestation of IBD. Sometimes you just don't get that. Maybe 2 years down the road, you will get the IBD related features. So we could be dealing with something here. Yeah. All right. Back to you, Manesuni. A very intriguing case. I definitely am learning a lot by listening to Maddy and then reciprocating or bouncing ideas off of her.
Same to you, Ravi.
That was an absolutely amazing discussion. I'm getting to learn so much just watching you walk through this case. So this patient was very challenging because his pain wouldn't go, and he had no GI symptoms, no diarrhea, or any changes in bowel habits. And talking about his joint, there was no joint pain or any joint symptoms. And on his foot X-ray, we previously, when he went to the urgent care, they saw soft tissue swelling, and which is why they thought of plantar fasciitis. But his pain just wouldn't go. And coming to my third aliquot, so we were wondering about what was going on with the patient, and rightfully so, we thought about imaging. And since X-ray was normal, we considered doing a CT and an MRI. In owing to the pain and increase in WBC and the raised ESR, we were thinking of infection. So when we did a CT, I was hoping to share the image, show the image of the CT so we could look at it together, if that's all right.
Absolutely wonderful. Yeah, we'll try and determine the reading.
And Manaswini, you are sharing your screen now. Yep.
Okay. Got it. Thank you so much. So this was the CT and the MRI of his right foot. Would love to discuss the impressions if you.
Okay, so I was trying not to look because all your other slides were there, so I didn't want to. Yeah, I've done I've goofed up before. I showed slides with the diagnosis, so I've committed that issue before. So, but I'm glad you don't have the diagnosis there. So it allows us to be challenged. But it was interesting. I don't look at a lot of the CTs or MRIs of the foot, but anything sticks out? Maddy, have you been learning to read these images?
I also don't have too much experience looking at, specifically foot CT and MRI, but, I think I'm trying to rule out the big scary things that are maybe more accessible for me to look at on the CT and MRI. So big things I'm trying to see, are there any obvious fractures? We're not getting a sign of kind of just from the history and the data we have so far, I wasn't so concerned about, a deep space infection at this point, but looking to see if there's any fluid collection or abscess that we're seeing here. And looking at the CT, just kind of scanning my cursor over the bones, I do not believe I'm seeing any obvious fracture, at least that's standing out to me. I'm not seeing any fluid collection. What else? So there's nothing that's jumping out to me on this. I would really be relying on the radiologist read here. And then same for the MRI. I also don't know, like, is there soft tissue swelling here? I don't know if I can confidently say that, but I would kind of be pulling up. I'd probably be, in real life, if I didn't have access to a radiologist, I would Google normal CT of kind of the right foot with contrast, normal MRI, and be comparing it to see what the big changes are. But there's nothing obvious that's jumping out to me here. Ravi, what about you?
I think, yeah, great job trying to use your established knowledge. And I think, yeah, I love that term, big scary things. And what's interesting, Hans also commented, if you go from distal, we lost it for a second, but yeah, if you look at the outer skin at the plantar surface and then look inward, so the skin doesn't look exaggerated. It looks approximates the thickness that it should be. And then just in front of that's likely the fat. There's always a layer of fat that's there. So you have the plantar fat layer, and you can see all this sort of septation there and so on. So this is probably the fat layer, and with time,
Yeah.
this tends to shrink as well because it's like a cushion.
Right.
And then just below that is the tendon, and it almost has the contrast of muscle. If you look like you can see part of the Achilles, and then also the tendon there and the muscle, and it sort of has that same sort of contrast, but it looks very thick to me. I don't know.
Yeah, I do see
Yeah,
what you're saying. Like you're seeing on the
yeah,
bottom, as you said, kind of that layer of fat, and then you're
yeah.
seeing kind of that layer of muscle here. And you're right, it does look thick. I'm not sure if that's more than usual. Again, I'd be comparing to kind of a normal CT, but I do see what you're saying there.
Yeah, and yeah, Sarah commented. Yeah, we remember we talked about the arch, how arch support is necessary. This foot kind of looks, I don't know if the cut is away from the arch, but that will be interesting to see if there is support of the arch as well there, or if there's a flat foot. Flat footed in itself is a foot that tends to have a lot of pressure and stress on it, and there can be inherent pain. And
Yeah.
then looking at the MRI, we're seeing all the muscles here. They also look kind of large. I don't know. I definitely would need a radiology. I haven't been exposed to MRIs of the feet much, but again, the bones,
Yeah.
I don't see any abnormalities, but we're seeing the muscles between or the tendons, maybe muscle or tendons. But they also look kind of exaggerated, or they could be normal. Again, I don't look at these much, but this is interesting. I always like to be challenged and learn. Let's turn it over
Yeah.
to Manaswini to get the official interpretation.
Those were some engaging thoughts. Now, so on the radiologist mentioned that there is a lytic lesion in the cuboid bone, and that was on the CT, and we see the same lytic image on the cuboid bone here, is what I learned from this. And so we did this, and coming to my fourth aliquot, we did the CT and MRI and found a lytic lesion. And we were trying to figure out why there was a lytic lesion, and did CT of the chest to see if there was a primary for the lytic lesion. And on the CT, we saw prominent bilateral cervical, axillary, and mediastinal lymph nodes. And there was moderate lytic lesion in the mid-sternum and the manubrium. And there was also an atrial mass that was seen near the IVC, and anterior mediastinal mass as well. So in order to further evaluate the mass in the heart, we did a TTE and it was shown that there was a large intracardiac mass present in the right atrium, primarily in the interatrial septum, and it was granular and speckled in appearance. So I learned that granular and speckled appearance might not be a myxoma. And that comes to the end of my fourth aliquot. Would love your thoughts.
Oh, it was interesting, Maddie. You were looking at that, or there was a cursor on that. And wow, yeah, so lytic lesion in the foot. Now we have to, this is quite a deviation from what we were thinking, autoimmune phenomena. There clearly is inflammation, but now of the bone and destruction. Before I kind of dive into a couple of things, I think, what do you think with a condition? What could cause this? We'll get to the heart and the finding in the heart. What do you think of this?
Yeah, I mean, this really has gone from, initially we were focusing on this pretty localized lesion to the foot, and now we're really seeing evidence of a systemic disease that's affecting the bones. There's like kind of diffuse lymphadenopathy, and we're also seeing this mass. I'm not really sure where to go from here. I think, lytic lesions, I think of, do we need to rule out malignancies? Are there infections that are causing these lytic lesions in the bones? With this diffuse lymphadenopathy, do we need to be worried about basically an underlying, like bone cancer, or sorry, a blood cancer that's causing the lymph node enlargement and the bone lesions? But I'd love to hear your thoughts, Ravi, so I'll pass the mic to you.
Yeah, it's
Oh,
kind
there's
of
masses as well. I didn't see the mediastinal mass as well, but yeah, go ahead.
Oh, no problem. Yeah. Well, what's interesting with this lytic lesion now, we have to start thinking, you're absolutely right. Yeah. Malignancies really do. I mean, you have to think about malignancies in younger people where you get these lytic lesions. You have to ask why, first of all, do you get lytic lesions? And lytic lesions would be from a lot of times, so certain malignancies. What struck me first when she mentioned these lesions, certain I guess metastases can be lytic in nature. I'm forgetting there is a list, and it's been mentioned on VMR before. So metastases, myeloma can have a feature like this too, and a certain plasmacytoma, solitary cell plasmacytoma can manifest. But this patient has too many things going on for it to be that variant of paraproteinemias. So in this case, I would think about metastasis, myeloma, and then take it from there. The list of primary bone tumors, we have Ewing sarcoma, osteosarcoma, those. I would start with these, consider these, do a workup for paraproteinemias, and then start thinking eventually we may have to do a biopsy to see if this is primary or if this is a metastatic lesion. Rarely would what if we are dealing with an infection? What could mimic this? Before even considering the heart, certain infections could target the bone. There could be infections like TB that could do it, or fungal osteomyelitis, but I don't get that sense here. Those are usually insidious, sort of slow growing. So it could sort of escape the immune system and not have a sepsis or SIRS-like response. But I think we also may have to consider that bucket. But these lymph nodes, now let's bring that in. Okay, we got lymph nodes, we got this mass in the atrium. Could that be the answer here? Or could it be a complication of this? Thrombosis, we know, can be a complication. Could this be, let me see, which atrium is this large in the right atrium? So this could be a tumor emboli, or it could be an embolus, a PE, or what do you call it, a DVT, in propagation to the pulmonary vessels caught in the right atrium. So from the right atrium would go into the pulmonary vessels, or it could be a tumor emboli. So we do have to think about that. What kind of tumor emboli could cross over to the bones and cause these lytic lesions? That I'm not sure, but definitely something needs to be biopsied, whether it be lymph node, maybe the bone. And I'm kind of interested, what is this mass in the atrium? Could it be associated, or could it be a complication, namely thrombosis from malignancy? Wow, what a shift. Manaswini, what a shift in this case.
Love the discussion. Thank you so much. So I'll be presenting my fifth aliquot. So in this patient, we did a serum and urine electrophoresis, which was negative, and his autoimmune panel came back negative as well. And while doing the CT chest, we saw that there were multiple subcutaneous nodules present in the CT. So a CT of the abdomen was performed, where we saw that there was a mass, a soft tissue nodule present in the left paraspinal area. And we also saw that there was mild splenomegaly in this patient. And we also did a CT guided biopsy of the foot, which came back indeterminate. And since we realized this was a challenging case, we decided to transfer the patient. And in the process and during the clinical course, he also developed one episode of febrile illness. And thinking of infection, we tried to rule out EBV, CMV, and HIV, which came back negative. And that would be my fifth aliquot. Any thoughts? Would love your thoughts.
Yeah, geez. I mean, I think, when you have so many abnormalities here, it's so many abnormalities in a case, it's helpful to kind of pick through the abnormalities and figure out which will have kind of the narrowest differential diagnosis to help make progress. And I think there have been so many great thoughts in the chat. I think Mark highlighted especially that, when looking through these abnormal findings, what in my view would help make the most progress is, I think, thinking about the mediastinal mass and the intracardiac mass, because those two really are feel unique in my mind. And I think the lytic lesions and the axillary mediastinal lymphadenopathy, I think, are separate to the process that's causing multiple masses. So maybe just to start, if we kind of think of that overlap between anterior mediastinal mass and intracardiac mass, when you think of the mediastinal mass, you want to break it up on which compartment is it in? Is it in the anterior mediastinum, the middle, or the posterior mediastinum? And the anterior mediastinum, that's, we've probably all learned in med school the different T's, the terrible T's, including a thymoma, a teratoma, like a germ cell tumor, or a terrible lymphoma. And I'm trying to think, of those, which of those could be responsible for the other findings that we're seeing here. And I think lymphoma is something I would want to rule out here, because if you think of what can cause diffuse lymphadenopathy, splenomegaly, masses in other locations like the heart, I think lymphoma is something I'd want to rule out. So I think what I would do is I'd probably just get an LDH to start. And then I think what I would probably advocate for is a biopsy of one of the masses, either whatever is more accessible. And I would imagine probably the mediastinal mass, if that can be accessed. What are your thoughts, Ravi?
Yeah, I think absolutely. There's nothing that really gives me a signal. I would just sort of reiterate what kind of I mentioned. I mean, the cause could be many. If we think about domains, metastasis still could be a play. That especially the ones that can be lytic in nature. We've already ruled out, we were thinking paraproteinemias, we were thinking some of the viral infections where typically they won't have this sort of signature or pattern. But again, this patient's from India, so TB can mimic anything, right? So say you have granulomas, the biopsy comes back granulomatous disease, definitely that's high on my radar screen. One other condition which can result in, there was a scheme I did on this, which is Langerhans cell histiocytosis, could be a thought. Young person, lytic lesion in the bone, multisystemic inflammatory disease may be something as well. But the biopsy will help us. Like Sarah mentions, very sneaky. But again, I can't say with confidence that it is this condition. But let's see. The biopsy will give us the clue, at least. Hopefully. Back to you, Manaswini.
That was very thought-provoking. So we did do LDH was 150, which was normal, and we did a flow cytometry, but it was not viable. And so we decided to do the biopsy of the soft tissue mass we see in the CT of the abdomen. And it came back to be showing, a lot of histiocytes in the soft tissue mass. And we see that there was a classical finding that I learned from the pathologist, which is emperipolysis, which is a cell eating another cell. And that is what we see here, which is classically seen in two conditions. One of which is autoimmune hepatitis, and the other one being the patient's what we see in our patient, which is Rosai-Dorfman's disease. So that is what the patient was ultimately diagnosed with. And as Dr. Singh correctly mentioned, it was non-Langerhans cell histiocytosis that we see in our patient. And that was the diagnosis of our patient. And it was very challenging when I encountered him. He was very anxious because all of us were working the case up, and he was strong throughout, but also anxious. And it was wonderful being there for him. And it was just amazing to collaborate with pathology and radiology and get all the information and the specialists and finally come to this diagnosis.
Wow, Manaswini, first case, such a great amount of teaching. I'm so humble, very humble case. But I really appreciate you making my day, because this is going to be on my mind for the entire day. I think I probably will have to reflect on this. But what a journey. And this just demonstrates how important. We talked about foot. We started with the foot, and look where we ended up. So it's really important to be in these discussions and to remind ourselves, because I don't think we talk about these conditions. Rosai-Dorfman disease, I don't commonly think about. Maybe in a poster at a poster presentation at ACP or one of these conferences, but it definitely will be at the front of my mind if I do encounter this. So I really appreciate you putting this case together, spending your valuable time and also your valuable evening to present this case. Can't say enough for what you've done for us today. Thank you.
Yeah,
Thank you
absolutely.
so much.
Oh, Manaswini, I know we're at time, but I would just love to hear kind of your reflections. What was it like for you to take care of this patient, and what did you learn from the case?
So I was involved in the initial part with the patient. I saw him come with foot pain, and the pain just wouldn't go. And we were thinking of osteomyelitis, and that was my first thought. But which is why we did the CT, and it ended up unfolding into something much bigger. So I would also like to mention that we did a FNAC of his right soft tissue and did an immunohistochemistry, which led to this diagnosis. That would be more more pathologically involved, but it was just wonderful to interact with him, go through this process with him, and he's now on off clinical trial for cobimetinib, which is MEK inhibitor. And I got to learn so much from just this patient, and it was just spectacular to be a part of this and present it on the VMR. I'm so grateful for this opportunity.
Yeah, thank you so much for your really fantastic presentation. I'll be thinking about this case like Ravi for the rest of the day. And so can't wait to learn more. That you simulated a lot of, I think, just like great discussion, and it was so much fun. So thank you for taking the time. And Eugene, we'll pass the mic to you for teaching points.
So thank you. I had a power outage, so sorry for the darkness. So we started off with a young male patient who presented with right foot pain. So the approach was to think anatomically, if you want to think about a unilateral pain in any extremity. So you're going to start with a soft tissue, so skin, soft tissue, could be cellulitis, necrotizing fasciitis, or you could go with the vasculature, bones, muscles, tendons, ligaments. Any pathology in these areas could actually lead to a unilateral extremity pain. Some differentials for if you're thinking about just foot pain could be overuse pain, arthropathy, fractures, maybe just poor footwear or Morton's neuroma. And then we had that the patient was already diagnosed with what we call plantar fasciitis. So plantar fasciitis is basically an intense pain in the heel though it has the word fasciitis, it's not really an inflammatory condition. It's more of a wear and tear. And so patients usually has pain early on in their walk, and then when they are ambulating, it tends to get better. And Dr. Ravi mentioned that there's a test called the windlass maneuver, which is basically doxyflexing the foot, and you're able to when that reproduces the pain, you can think that that's positive. Basically, you are stretching out the fascia, and that could tell that the patient actually has the plantar fasciitis. And causes of these same plantar fasciitis could be as a result of overuse, could be as a result of poor footwear. And we also got some systemic fingerprint with this patient. This patient had months of fatigue and generalized body ache. We had tachycardia. We had some form of elevated inflammatory markers, microcytic anemia. And then we also had some slightly elevated white cell count. So our thought process was, could this be a systemic condition that is leading to the plantar fasciitis? Or, I mean, thinking about PER, that is psoriatic arthritis, IBD. So we were thinking, should we ask more GI questions? We're also thinking reactive arthritis. And also ankylosing spondylitis. So Ravi taught us that when you have a situation like this, you want to examine all the various tendons and the ligaments in the extremities and ask more questions. And then to focus on the foot, you can do imaging, that this is an X-ray, CT scan, or MRI. And there was a turning point in the case where we did a CT scan and we saw a lytic lesion. Once you see a lytic lesion, you can you begin to consider whether it's a primary bone lesion or is it a metastasis from some other primary site. Could this be a multiple myeloma or a plasmacytoma, or could this be just an osteomyelitis from various causes that could lead to a bone infection? And we named them TB, viral infections, all of that. And then we also did some more workup and saw diffuse lymphadenopathy, mild splenomegaly, and an intracardiac mass. Intracardiac mass, we were thinking, could this be a thrombus? Could this be metastasis? We also thought about the diffuse lymphadenopathy. When you have diffuse lymphadenopathy, you want to biopsy the most abnormal lymph node. You're thinking around lymphoma. You always make sure that you rule out lymphoma. And Ravi had a schema where he said that when you put all three together and you're thinking about how this patient's presentation, you could think about either Langerhans cell histiocytosis or non-Langerhans cell histiocytosis. And non-Langerhans cell histiocytosis has multiple subtypes. In this case, was the Rosai-Dorfman disease. It's the difference between is with the immunohistochemistry as described by Manaswini. And so, yeah. Some other subtypes that of head comes to mind is HLH. I think there are other subtypes. So this is where I'll put the teaching points. Very fantastic case, and lots of teaching in it, lots of learning to do personally for myself, and I hope everyone else enjoyed the case. Thank you.
Absolutely amazing, Eugene. You captured everything, and it was so structured and clear. So thank you so much to Eugene, to Bayan, Manaswini. Thank you again for your phenomenal first case presentation. I hope this is the first of many. And Ravi, what a journey together. This was really challenging case. I thought your discussion was so brilliant, and look forward to reading more about this.
Yeah, absolutely, Maddie. Wonderful time discussing with you. I applaud you. Such a difficult scenario, but you came in and you mentioned a lot of great things. So amazing. Such a high level discussion from you at this level. It's just exemplifies what CPS can do for your learning. So kudos, and keep coming back and keep signing up to discuss. I would love to go discuss again with you. Thank you as well, Manaswini. Great presentation.
Thank you so much, Dr. Singh, Maddie, and Eugene. Thank you, everyone. It was absolutely wonderful. Thank you so much.
All right. Well, have a great rest of your Tuesday. Have a great day off, Maddie. Enjoy.
Bye.
Take care. Bye.